Dr. Perry Carpenter. I'd like to thank you for taking the time to join me on this week's video. On this week's video, we're going to continue with now part 2 of our two-part video series related to the pain-related impairment. And as I said, this is video number 2. If you have not seen video number 1, I've included a link in this week's blog so that you can easily access video number 1. And the purpose of this 2-video series is to elaborate on concepts taught in Chapter 18 of the AMA Guides. And as you know, Chapter 18 is the chapter associated with pain, and it describes the principles and procedures there that are involved with providing for additional pain-related permanent impairment. In other words, we as qualified medical evaluators have the flexibility to use our clinical judgment and to award a discretionary additional permanent impairment rating for the added burden of pain in addition to any conventional impairment rating that we provide for our examinee. And it's Chapter 18 that we rely on for the principles and the procedures that govern whether the determination as to whether or not our examinee qualifies for additional permanent impairment related to pain. So between video number 1 and video number 2, which is today's video, this is a complete course on additional permanent impairment related to pain. And this is material that you cannot find anywhere else. I say that with authority because I do attend many continuing education seminars for qualified medical evaluators, and the topics that we discuss in these weekly blogs you cannot find anywhere else. These are QME trainings that come from the trenches and come from experience of doctors all up and down the state doing thousands and thousands of QME examinations over the course of many decades. So what you're receiving in these weekly video blogs is the combined wisdom and experience of some of the very best qualified medical evaluators in the entire state. And it's my pleasure to be your presenter, although I'm not necessarily the sole author of all of these blogs. It is my sincere pleasure to be able to be the one that brings you these weekly trainings. So this is a complete course on providing for pain-related impairment. And before we get into the topic of today's discussion, I just want to go over a couple of announcements. Number 1 is that I'm very excited about the progress of our weekly blogs. What's happened over the past couple of months is due to subscriber feedback, we're now presenting topics that are sort of at the top of the hit list of qualified medical evaluators. In fact, today's topic on the pain-related impairment comes at the request of one of my subscribers, at the request of several of my subscribers who had questions about the proper procedure involved with providing for pain-related impairment. So we're embarking on a series of blogs over about the next 60 to 90 days designed to address some of the common questions that today's qualified medical evaluators are encountering. So the message that I want to share with you is that if you have some question or you have some concern about the QME process that you'd like to have us elaborate on, simply send me an email or give me a phone call, and I will put your topic on our list of upcoming blog topics to discuss. And we're actively soliciting your concerns because we figure that if you have some unresolved question or some unresolved issue, then probably other evaluators do as well. And so it'd be our pleasure to research those topics for you and provide you with a full training session on your particular question. So that's one thing. And then the second thing is, as an upcoming announcement, I want to let you know that I will be speaking on June 27th for the California Chiropractic Association. They will be holding one of their, what they refer to as their right in your backyard continuing education seminars. and I'll be presenting QME recertification for 6 hours. And I want to invite you to attend that presentation because we're going to be going over some topics in that presentation that are completely unique, that you cannot find anywhere else. And I plan on presenting to you 6 hours of the most relevant and timely material up to the minute current in relation to the modern chiropractic and medical qualified medical evaluation. And over the course of the next several weeks, I'll be sharing with you some of those topics. And I want to let you know that for today, if you attend that presentation, you can count on 90 minutes of presentation about how to create compelling and persuasive medical reports that qualify as substantial medical evidence. And just to elaborate on that topic a little bit here before we get into today's material, I want you to know that over the course of the past 6 months, I've had the opportunity to review hundreds of QME reports from a variety of different specialty providers, chiropractic providers, medical providers, psychology providers. And I've been able to dissect these QME reports with a fine-tooth comb to come up with the elements that create the most compelling, the most credible, the most persuasive, and the most substantial medical reports. And I'm going to be presenting for the CCA on June 27th about 90 minutes on how to create compelling reports. And I'm going to show you what are the factors and elements that conspire to detract credibility from your QME report. And conversely, what are the factors and components that tend to add credibility and add persuasive power? And what are the components that contribute to making your report substantial medical evidence? And basically, what makes your reports irrefutable, ironclad, solid conclusions, solid opinions that are supported with how and why. I'm going to be sharing you the components that contribute to the very best qualified medical evaluation reports throughout the entire state of California. So that's going to be a don't miss session. And I'm also going to be providing for attendees at that presentation, I'm going to be providing for you a template that you can use to integrate into your current QME report or to completely replace your QME report that is going to be the most fabulous and the most beautiful and the most perfectly constructed template that we have available to us. I say this with authority because I know everything that's available in the industry, and this is the very best template that includes all of the components required to produce compelling and substantial reports. So that will be a don't miss presentation, and I want to invite you to attend that presentation. That's on June 27th. That'll be at Squaw Valley, California, in and around northern Lake Tahoe area. And if you do attend that presentation, I'd like to have you take a moment and come up and introduce yourself to me. I would look forward to meeting you and getting to know you and shaking your hand and having a brief, or perhaps a brief chat about all things QME. So I'm sure you'll be hearing much more about this in the future, but to reiterate, I'm inviting you to be my guest at QME Continuing Education Recertification, June 27th at Lake Tahoe, Squaw Valley. And for more information about that, you can go to www.calchiro.org, search for their Right in Your Backyard seminars, and you'll see it clearly listed for June 27th and June 28th in Squaw Valley. Okay? Okay, so let's get into the topic of today's presentation. This is part 2 of our 2-part series on the pain-related impairment. And in part 1 of our series, part 1 video, we talked about when and when not to use the AMA Guides Chapter 18 for the provision of additional permanent impairment related to pain. And the AMA guides are very clear that there's a very specific set of circumstances for which examinees can qualify for additional pain-related impairment. And if you remember the recurring theme and the take-home message from video number 1, and that is the majority of examinees will not qualify. They will not qualify for additional impairment related to pain. So we talked about when to use and when not to use Chapter 18, and then we talked about who does and who does not qualify for additional impairment related to pain. And we'll touch a little bit on these topics as a manner of review in today's video, which is part 2. In today's video, we're going to talk about actually how to perform the pain-related impairment assessment. We're going to go over today the actual procedures that you as a doctor will mechanically go through in the face-to-face evaluation, and then later at your office when you have quiet time and you're working on the report. We'll talk about exactly what you do procedurally in the decision-making process as to whether or not you opine that your examinee qualifies for additional impairment related to pain. And this is going to be a fascinating and valuable discussion for you, because I found in speaking with many doctors, there are many steps and procedures that doctors are omitting in this procedure. And I found even there are many doctors that do not do any sort of a pain-related impairment assessment. And let me give you an example of that. In the past 7 days, actually since we issued video number 1, in the time between then and now, which has been about 7 days, a qualified medical evaluation, or I should say a comprehensive medical legal evaluation, came across my desk for my review and opinion, and was sent to me by a defense attorney who asked me to comment on the opinions and conclusions in this comprehensive medical legal report. It wasn't a QME evaluation, it was a primary treating physician's designated physician who prepared the medical legal report. And in this medical legal report, the evaluating physician opined for 3% additional impairment due to pain, in addition to multiple other impairment ratings, both under the conventional impairment rating system and under Alvarez-Guzman 2, and all these different permanent impairments. They also provided for additional 3% impairment related to pain. And there was no formal pain-related impairment assessment to back up the evaluating doctor's opinion for additional impairment related to pain. And I opined that this opinion for additional impairment related to pain did not explain how the examinee qualified for additional pain-related impairment, did not explain why the examinee qualified for additional pain-related impairment. There was nothing to substantiate this additional 3% whole person impairment. And so I opined that the opinion did not qualify as substantial medical evidence on the issue of permanent impairment. And it was a grave error by the evaluating doctor that he did not substantiate in any way, his opinion for additional impairment related to pain. And I can tell you that not only is that opinion on permanent impairment not going to be upheld, the whole opinion on permanent impairment was not persuasive. It was not persuasive. And we're all about producing reports that are credible, that are persuasive, and that qualify as substantial medical evidence. So in today's video, how to perform a pain-related impairment assessment, I want to go over the nuts and bolts procedure that the AMA guides require for the provision of additional impairment related to pain. So that if you do opine for additional impairment related to pain in your report, Your opinion will be substantial. It'll be clearly explained as to how and why you arrived at this conclusion. And basically, your opinion will be upheld, and it will be irrefutable. It'll be substantial medical evidence. So, we're going to get into today's topic, and I'm going to ask you to go ahead and get your AMA guides. We're going to be on page 576 and 577 of the AMA guides. Yeah, 576 and 577. And on those two pages, the AMA guides have printed for us a copy of the pain-related impairment questionnaire. Now, if you have a digital copy or a PDF copy of the pain-related impairment questionnaire, I'm going to ask you to go ahead and retrieve one of those questionnaires, because we're going to dissect this questionnaire with a fine-tooth comb, and we're going to go over this together as to how this form gets completed by the examinee, and then how you as the evaluator use this form as a tool for the assessment of the rateability or the unrateability of the pain-related impairment. So I'll give you a minute to go ahead and either get the pain-related impairment questionnaire, or if you don't have that, go ahead and get your AMA guides and open up to page 576, and we'll begin in just a couple moments on today's topic, which is part 2 of the pain-related impairment assessment. Okay, I'm back with you now, and I have my AMA guides with me. I hope you have your AMA guides with you as well. If you do, I'd like to have you open up to page 576 and 577 as we go over the pain-related impairment questionnaire today. Now, before we get into that, I just want to review a couple of things from video number 1. And in video number 1, we established a couple of basic principles related to the pain-related impairment. Principle number 1 is that we're going to do a pain-related impairment assessment on every single case. On every single case. We're going to do a pain-related impairment assessment on every single case. Now, this is slightly different than what the AMA guides describe as the procedure for performing a pain-related impairment assessment. According to the AMA guides tell us that if in the course of our interview and examination with the examinee, we determine that the applicant may be suffering from the additional burden, or they might be suffering from excess pain, it's at that point that we make the decision to go ahead and perform a pain-related impairment assessment. But in my experience, I believe this to be an impractical suggestion. And what I suggest is that you prepare in advance to do a pain-related impairment assessment on every single case. And the reason for that is the additional permanent impairment related to pain many times has a lot to do with what you determine to be the permanent impairment according to the conventional impairment rating system. So for example, when you're with the examinee taking your interview and taking your physical examination measurements and your readings and calculating your angles and all the stuff that's required by the AMA guides, that is not the time that you can adequately or accurately determine which of the permanent impairments the examinee qualifies for. Many times the determination of the exact permanent impairment does not come together until days or even weeks later, after you've had a chance to sit down at your office with all your file materials, Perhaps you've had a chance to order and look at additional diagnostic studies, and you work on the report, and then the permanent impairment rating comes together long after you've dismissed the examinee. In other words, it's not possible to know during the face-to-face evaluation with the examinee exactly what your permanent impairment rating is going to be. So if you decide later that your permanent impairment rating does not consider the impact of pain on the examinee's condition and on their activities of daily living, you've already completed the pain-related impairment assessment, and you can pull that information out and then integrate it into your final permanent impairment rating. It's simply impractical, if not impossible. I'm not going to say it's not possible, but it's certainly very impractical to decide later that, oh, you know, perhaps this examinee could qualify for additional impairment related to pain. I better go back and do a pain related impairment assessment. And then you try and get another face-to-face evaluation with the examinee, and it's just inconvenient, awkward, bulky, cumbersome, and it's clumsy. So as an alternative to the procedure described in the AMA guides, it's been my experience that it's much better to just plan on doing a pain-related impairment assessment on each and every case. That way you have the information should it become necessary, and if you decide that the examinee does not qualify for additional impairment related to pain, then you simply don't use the information, but you have it should it become necessary. And let me give you an example to illustrate this. I said that the determination as to whether or not your examinee qualifies for additional pain-related impairment many times has to do with what you decide is the actual permanent impairment according to the conventional impairment rating system. Remember that in Chapter 18 there's 3 separate and distinct scenarios under which we can provide for additional impairment related to pain. Number 1 is when there's a well-established pain syndrome that is not otherwise rateable according to other chapters in the AMA guides. Well-established pain syndromes, and the best example of that is the pain syndrome of headaches. For example, migraine headaches. Migraine headaches are not associated with any identifiable organ dysfunction that can be rated by any of the other chapters of the AMA guides, and for that reason Chapter 18 allows us to provide for up to 3% whole person impairment for the pain and limitations in activities of daily living associated with headaches. Headaches is a well-established pain syndrome, and there are others. Those are described in Table 18.1 of the AMA guides. Second scenario wherein we can provide for additional impairment related to pain is when there are associated pain syndromes that are associated with bona fide medical conditions that can be rated according to other chapters of the AMA guides, but sometimes those other ratings in the other chapters of the AMA guides do not adequately capture the added burden of pain on the permanent impairment. And the best example that the AMA guides use to illustrate this principle in this situation is the examinee who has had an amputation who then complains of phantom limb pain. And phantom limb pain is an associated pain syndrome that is associated with amputation. Now, the permanent impairment rating given in Chapter 16 for amputation is the same for all examinees, whether they have pain or they don't have pain. Not all examinees who have an amputation report phantom limb pain. Well, those that report no pain get the same impairment rating as those who report pain. In other words, the permanent impairment rating associated with amputation does not consider the impact or the presence of pain. It's simply associated with the amputation. So phantom limb pain is an associated pain syndrome that accompanies a bona fide medical condition that can be rated according to other chapters and tables of the guides, but those ratings do not consider the impact of pain. So that's scenario number 2. And then scenario number 3 that does allow us to provide for additional pain-related impairment is those situations wherein we determine that the examinee has what we consider to be excess pain above and beyond that which we would reasonably expect to be associated with their medical condition. And we recognize that many of the permanent impairment ratings within the AMA guides already consider pain, but there are many impairment ratings within the AMA guides that are not associated with pain at all. So let me give you a couple examples of those. And let's take a couple of examples from Chapter 15. If you look at Table 15.7 in Chapter 15 of the AMA Guides, this is the table that's associated with the specific spine disorders that we use in providing for permanent impairment related to the range of motion method. So I'd like to have you turn to this page in Chapter 15. This is page, get right to it, this is page 404 in Chapter 15. You'll notice entire section number 1 associated with fractures. These permanent impairment ratings are not associated with pain. So if you read these descriptions, you have permanent impairments related to compression fracture of the vertebral body. You have permanent impairment ratings related to fracture of the posterior elements. You have permanent impairment ratings due to reduced dislocation of one vertebra. And none of these permanent impairment ratings have anything to do with pain. There is no description of pain contained within the definitions of these permanent impairments. These permanent impairments are simply the impairments that we associate with these conditions, with a fracture of the vertebral body, fracture of a posterior element, or a reduced dislocation. Now, if you look at section number 2, related to intervertebral disc or other soft tissue disorder, you notice that these permanent impairment ratings consider the impact of pain on the examinee's condition and on their ability to perform activities of daily living. So for example, category number C describes an examinee who has intervertebral disc or other soft tissue lesion that is unoperated on. It's stable with medically documented injury, pain, and rigidity. Medically documented injury, pain, and rigidity. So if you opine that the permanent impairment due to specific spine disorder under the range of motion method is category number C, they have an unoperated on soft tissue or disc lesion that has left them with pain and rigidity, the pain is already included within the definition of this impairment. This is an examinee who would not qualify for additional permanent impairment related to pain unless, in your opinion, for some reason, they had what you determined to be excess pain above and beyond that which you would expect for this type of permanent impairment. Let's look at section C with spondylolysis and spondylolisthesis, non-operated on. The definition says that we have a spondylolysis accompanied by medically documented injury that is stable and medically documented pain. The pain is included in the definition. So if you have an examinee that comes in and says, I have a spondylolisthesis and I have pain. Oh man, the pain. Let me tell you about the pain. I have pain in the morning, I have pain in the afternoon, I have pain in the evening, I have pain at night. Pain at night prevents me from being able to sleep. When I wake up in the morning, I'm more tired than I went to bed. I have pain all day. Pain goes down my leg. Pain causes me to have stiffness in my back and I can't concentrate at work. And when I go to stand up, I can barely stand up straight because of the pain. And I have muscle tension and spasms around my low back and it's so painful. And I have pain, pain, pain. They do not qualify for permanent impairment related to pain because the pain is in the definition. The pain is adequately subsumed and described by the permanent impairment rating under the conventional impairment rating system. And the same thing applies in Chapter 16 and in Chapter 17. Many of the permanent impairments already include the pain. What are some of the impairments that are unrelated to pain? Well, if we take a look at Chapter 17, Chapter 17 allows us to provide for permanent impairments related to anatomic losses, due to functional losses, and due to diagnosis-based conditions. And some of these permanent impairments are simply provided for due to loss of anatomy, loss of function, or some specific diagnosis unrelated to pain. So for example, one of the permanent impairments due to anatomic loss involves a limb length discrepancy. Limb length discrepancy. Let's say you had an examinee who suffered a fracture of the tibial plateau or a fracture of the femoral neck. I'm just making this up. They had a fracture of the femoral neck and it healed with shortening of the limb. They could qualify for permanent impairment due to limb length discrepancy, and the limb length discrepancy is unrelated to pain. Some people can have a limb length discrepancy and have no pain, but others can have pain associated with the condition, but the condition does not include the impact of pain. So for limb length discrepancy, I can see scenarios where you could provide for additional impairment related to pain. So let's go back to the purpose of this discussion. The purpose of this discussion is to illustrate the point that many times the determination as to whether or not the examinee qualifies for additional pain-related impairment is based upon what you determine to be the permanent impairment to begin with. Because many of the permanent impairments already consider the pain, however there are some where the pain is not a component of the permanent impairment. So for that reason, we perform a pain-related impairment assessment on each and every examinee. Okay? So let's talk about actually how, since we agree that we're going to perform a pain-related impairment assessment on each examinee, let's talk about actually how to do it. How to do it. How do you do a pain-related impairment assessment? Well, the answer to that varies, and different doctors do this differently. But the very best evaluators have in common several components of their procedure. And the components that the very best evaluators share in common include a couple things. Number one is that the pain-related impairment assessment begins with a good activities of daily living interview. An activities of daily living interview. The very best evaluators do the activities of daily living assessment as part of the face-to-face interview with the examinee. Now, some doctors simply ask the examinee to fill out a checkbox form and to bring the form to the evaluation, or they give the examinee a checkbox form at the evaluation and ask the examinee to check the appropriate boxes and circle the appropriate numbers. And many doctors do not review that form with the examinee. They simply accept that form and they accept the responses of the examinee as accurate and true representations of the examinee's condition. But it's my opinion, it's my experience, and it's also the experience of the very best evaluators, that examinees need to be coached through the completion of symptom questionnaires, and they need to be coached through the activities of daily living interview and assessment, so that we as evaluators can arrive at true and accurate responses to our questioning about the impact of their condition on their ability to perform activities of daily living. And you're probably familiar with examinees who, not knowing the philosophy of symptom questionnaires and not knowing the philosophy of pain as it's described in the workers' compensation system, they will provide responses for us that are escalated, elevated, magnified, and are not true representations of the impact of their condition on their ability to carry on in daily living activities. And so it's our job as the evaluators to work with them, to arrive at responses to our symptom questionnaires, our activities of daily living interview, and then ultimately our pain-related impairment assessment that are accurate, that are accurate and a true representation of their actual condition. Not a magnified representation of their condition, not a minimized representation of their condition, but a true and accurate representation of their condition. And for that, the doctor needs to participate in that assessment to arrive at conclusions that are accurate. So the very best evaluators do the activities of daily living interview in the face-to-face evaluation. Now, let me give you an example of how the very best evaluators do the activities of daily living interview. The very best evaluators do the activities of daily living interview immediately before administering symptom questionnaires. So imagine this, you're face-to-face with an examinee and you're beginning your interview with them, and you're going through the various components of your report, such as the history, such as the relevant medical history, such as the social history, such as the current symptoms, such as any occupational history. And before you take a break from the history taking and the physical exam, before those two cycles of action, interview and then physical exam, there's a transition wherein the very best evaluators handle their symptom questionnaires and their activities of daily living assessment. And the activities of daily living assessment comes immediately before administering the symptom questionnaires, and the symptom questionnaires come immediately before the transition into the physical examination. So the activities of daily living interview would go something similar to the following. Okay, Mrs. Jones, in a couple minutes we're going to get into some physical examination, and I'm going to check you out very thoroughly. But before we do that, I just have one more line of questioning for you. And what I want to go over with you now is what we refer to as our activities of daily living assessment. We're going to be assessing the impact of your pain, your neck pain, your lower back pain, on your ability to perform activities of daily living, okay? And you get a head nod from them. And you say, So what I'm going to do is I'm going to ask you several questions about various activities that you might go through in the course of a normal day. And I'm going to ask you to think about your headaches, your neck pain, and your right arm pain. Your headaches, your neck pain, and your right arm pain. And I want you to think about how those pains interfere, if at all, if they do at all. They might not, but if they do, I want you to think about how your pains interfere with your ability to perform various activities. Okay? Okay. Okay, so the first category of activities that I want to ask you about involves your self-care and your personal hygiene. Self-care and personal hygiene. So let me ask you, Mrs. Jones, as a result of your headaches, your neck pain, and your right arm pain, do you have any difficulty using the bathroom for urination? And they will tell you. Now, without getting into the full activities of daily living questionnaire, there are certain conditions that will cause difficulty with urination. Mostly nervous system disorders, spinal cord disorders, spinal injuries. In the main, very few conditions are going to interfere with an examinee's ability to urinate. So typically the response to that question would be, no, I can urinate just fine. Okay, Mrs. Jones, as a result of your headaches, your neck pain, and your right arm pain, do you have any difficulty using the bathroom for defecation? And they will tell you. Usually it would be no. And you go through each of the activities of daily living in 8 major categories, individually, one by one, and you interview the examinee. And what you're looking for is you're looking for specific limitations or restrictions in activities of daily living as a result of the pain. Not simply limitations in activities of daily living for whatever reason, but specifically related to their pain, which is related to the industrial injury. So for example, an examinee might say, yeah, it hurts like hell to sit down on the toilet when I have to defecate. The follow-up question to that would be, well, why is that? Where do you hurt? And they might say, well, it hurts my right knee, which I had replaced in 1995. And see, that's unrelated to the industrial injury. So you have to work with examinees to get responses that are accurate for what we're trying to assess. It might be true that they have difficulty using the bathroom for defecation, but it's unrelated to the industrial injury. And this is a principle that many times examinees will try to falsely impute. Falsely impute. This is called false imputation. They will falsely impute their restrictions or limitations in activities of daily living to the industrial injury, when in actuality any restrictions or limitations are unrelated to the industrial injury. So the doctor works with the examinee through each of the categories of activities of daily living. So what's the purpose of this? The purpose of this is to arrive at conclusions that are true and accurate. And it's interesting because the activities of daily living that are described by the AMA guides are repeated in the Pain-Related Impairment Questionnaire. So we should get responses that are consistent on both the activities of daily living interview and the Pain-Related Impairment Questionnaire. Okay, so it begins with the activities of daily living interview to establish the basis and the foundation of the responses. And we check those responses for consistency and validity against the Pain-Related Impairment Questionnaire. Okay? So after we've done our activities of daily living assessment or interview, we then transition into the symptom questionnaires, which immediately precedes the physical examination. So that script might go as follows. Okay, Mrs. Jones, okay, so I'm going to prepare for the physical examination. While I do that, I have a couple of forms and questionnaires I'd like to have you complete. And you explain the forms and questionnaires to them. That might include an Oswestry low back questionnaire, an Epworth sleepiness scale questionnaire, and all these symptom inventories that we use. The last one of which is the pain-related impairment questionnaire. Now, the pain-related impairment questionnaire comes last. And you want to withhold the pain-related impairment questionnaire from the examinee while you give them the other symptom questionnaires you want to have them complete. And so that script might go as follows. Mrs. Jones, when you're done with these symptom questionnaires, I'm going to have one more that I need you to complete. So when you're done with these here, you let me know, and then I'll give you the last one. And they'll say, okay. Then when they're done with the symptom questionnaires, you take out the pain-related impairment questionnaire and you would say to Mrs. Jones something similar to the following. Mrs. Jones, you're doing great. I just have one more questionnaire for you to complete, and then we'll get on to the physical examination, okay? Okay. Now, Mrs. Jones, I want you to wipe your mind. I want you to wipe your mind for just a minute. I want you to forget the questionnaires that you just completed. And I had you complete many. I had you complete one on your back, one on sleeping situation, one on the pain in your leg, and all those things. I want you to forget those for a minute. For the purposes of this questionnaire that we're going to complete now, I want you to think about the combined effect of the pain of your headaches, your neck pain, and your right arm. And as you complete these questions, you're thinking only about the impact of this pain as it relates to the questions on this questionnaire. So for example, if there's a question on this questionnaire that says, do you have any difficulty walking? And you do have difficulty walking because you have a hangnail. That hangnail is not related to the pain syndrome related to your work injury. Do you understand? We're simply concerned here with the combined effect of the pain of your headache pain, your neck pain, and your shoulder pain. It's a little different philosophy than what we were talking about with the other symptom questionnaires. Do you understand? And you get a head nod from them that confirms to you that they're on the same page with you as to what the pain is that they're considering. Okay? So then they complete the questionnaire. And your job as the doctor is to review the responses of the questionnaire for consistency with the responses to the activities of daily living interview. And many of the questions are the same. So for example, if you turn to page 576 and you look at the pain-related impairment questionnaire, it asks them, how much difficulty do you have being able to walk one block? Well, walking is one of the physical activities of daily living that we assess for. So the response should be roughly consistent with what we elicited on the on the activities of daily living interview. Sitting is one of the activities of daily living. Standing is one of the activities of daily living. Sleeping is one of the activities of daily living. So the pain-related impairment questionnaire very closely matches and mirrors the activities of daily living described in the AMA guides. So you confirm and you establish consistency with the responses on the pain-related impairment questionnaire, and don't allow them to either maximize or minimize their responses, because it's the responses that we're going to rely upon later for the establishment of our pain-related impairment rating. Okay? Okay. So, let's get into the final stages of the pain-related impairment assessment. It begins with activities of daily living interview. It continues with the completion of the pain-related impairment questionnaire. Sometimes you'll see this referred to as the Impairment Impact Inventory. Impairment Impact Inventory. And it continues with a couple of subjective conclusions by you as the examining doctor. The pain-related impairment assessment allows you as the doctor to modify the examinee's scored responses, either up or down, based upon your assessment of their pain behaviors and based upon your assessment of their overall credibility level. Now, on another separate video, I've discussed pain behaviors in great detail. In fact, I have over 1 hour discussion solely on the pain behavior, so I won't reiterate that here. But we as the doctor are charged with the responsibility of assessing the examinee's pain behaviors and assessing the consistency of those pain behaviors with the presumed medical condition. And we are allowed to adjust either up or down their pain-related, the qualitative pain-related impairment score. So if you determine that an examinee is a very stoic examinee and who is under describing and under reporting their symptoms and activities of daily living limitations, you can adjust up the score based upon your clinical judgment. If you have an examinee who is expressing either inconsistent or exaggerated pain behaviors and you believe that they're perhaps magnifying their condition, you can then adjust down the impairment impact inventory score. Similarly, with examinee credibility is critical because the entire assessment of pain is based largely upon self-reports of the examinee. In other words, we rely almost totally on the examinee's descriptions of how the pain interferes with their activities of daily living. We have no way to be able to corroborate many of their descriptions, and so we rely on their descriptions. And so if you determine that an examinee is simply not credible, well then the entire pain-related impairment assessment is over, because the Chapter 18 disallows a pain-related impairment rating for examinees who have low credibility. And I just reviewed a report that came across my desk that had an examinee with low credibility, in my opinion. Low credibility for a variety of reasons that we won't get into here. But the doctor provided for additional 3% whole person impairment due to pain in an examinee that he did not perform a pain-related impairment assessment, and an examinee who, in my opinion, had very low credibility. So the credibility assessment is critical. If you don't find the examinee to be credible, then the pain-related impairment assessment is over. If you do find the examinee to be credible and their reports seem to substantiate and corroborate their descriptions of of pain and activities of daily living restrictions, then you can adjust up the permanent impairment rating score to come up with a quantitative pain rating that you can then use to provide for additional permanent impairment. Okay? So once you do that, you have your pain-related impairment questionnaire completed, and you can then later, when you're back at your office and you're working on the report, you can complete the pain-related impairment assessment, providing for your additional adjustment for pain behaviors and your additional adjustment for the credibility rating of the examinee, to come up with a qualitative pain rating score. And AMA guides describe mild pain, mild impairment related to pain, moderate impairment related to pain, moderately severe impairment related to pain, and then severe impairment related to pain. Once you have this rating, your decision falls into basically one of two domains. Number one, is the pain rateable or is the pain unrateable? And we describe three scenarios wherein the pain is rateable. If there's a well-established pain syndrome, if pain is due to an associated pain syndrome, or number three, if in your opinion there is excess pain. Those are the three circumstances wherein the pain would be rateable. If you determine that the pain, three situations wherein the pain is unrateable is when, number one, the examinee has low credibility, number two, when the pain syndrome is vague or ambiguous, and number three, when the pain is adequately rated and is considered in the conventional impairment rating. So let's say you have an examinee who, in your opinion, has headaches. You can then go ahead and provide for an additional 1, 2, or 3% whole person impairment related to the pain associated with the headaches. If the examinee has an associated pain syndrome that increases the burden of their illness, that is also rated by another chapter in the AMA guides, you can provide for an additional 1, 2, or 3% whole person impairment. Or if you determine that the examinee has an impairment that's described in another charter table of the AMA guides, but they have what you consider to be excess pain, you can then provide for an additional 1, 2, or 3% whole person impairment related to the pain. Now, in all situations wherein you provide for additional permanent impairment related to pain, you must establish a separate section within your report. So, for example, in your report you have a section entitled Permanent Impairment. Okay, you should have a section in your report, subsection under Permanent Impairment, that says Permanent Impairment under the strict application of the AMA guides, permanent impairment under Alvarez-Guzman 2, and then finally permanent impairment related to pain. So in every single case you have a discussion as to whether or not your examinee qualifies for additional permanent impairment related to pain. If you determine that the examinee does qualify for additional impairment related to pain, it's in this section of your report that you would explain how they qualify and why they qualify. And be thorough and be very descriptive in your formulation in order for your report to qualify as substantial medical evidence. So there it is. So, doctors, I hope this helps you. The reason we go through this discussion is because many doctors are providing for additional permanent impairment related to pain that is not substantiated in their report. And the additional impairment related to pain is not being held up. It's not being upheld. It's not sticking. And when you go through this formulation and you provide for additional permanent impairment related to pain that's not substantiated, according to Chapter 18 of the AMA Guides, according to the exact procedure described in Chapter 18 of the AMA Guides, it really makes suspect the credibility and thoroughness of your report. It calls into question the substantiability of your report and the credibility of your report. If one opinion or conclusion is not substantial, how many of the others are not substantial either? And so one way to shore up the persuasiveness of your reports is to make sure that every single opinion and conclusion is explained with how and why you arrived at that conclusion. And the pain-related impairment rating is certainly no different. It needs to be substantiated with the how and the why. So doctors, hope this helps you. This is the conclusion of video number 2 related to the pain-related impairment. I look forward to being with you again on future videos. And as always, this is Dr. Perry Carpenter. I'm wishing you best of success in your career as a qualified medical evaluator.